Welcome to this first in a series of continuing education sessions that we will be holding and recording for future use. Our presenters today are Michelle Flowers and Dr. Emily Hamilton. Our original presenter, Rebecca Seifer, who is PeriGen's Chief Nursing Officer, will not be able to join us because of illness. The series is envisioned as a special preparation for those looking to not only deepen their understanding about childbirth and to get continuing education units, but also in preparation for taking the exam for EFM designation. Michelle Flowers serves as PeriGen's program manager and clinical consultant. She's got 20 years experience in OB that includes coordination of clinical quality. She's been an educator for obstetric services and an L&D charge nurse. More recently, she's focused on designing and executing OB documentation workflows and training programs. Her education credentials include A1 Intermediate and Advanced Fetal Monitor Instruction, an ICEA approved trainer, and she's a certified childbirth educator and AAP NRP instructor. Dr. Hamilton is PeriGen's Senior Vice President of Clinical Research. She's an experienced obstetrician as well as an adjunct professor of obstetrics and gynecology at McGill, and she leads clinical research here for PeriGen. She's the inventor of PeriGen's fetal monitoring system, holds 32 U.S. and international patents for her research work, and speaks widely on the use of technology to improve obstetric outcomes. She presents regularly around the world and also writes articles and co-authors for peer-reviewed journals. So without further ado, I'm going to let Michelle take you through the objectives of today. This session does award one continuing education unit, and we'll discuss next steps at the end of the session.
Thank you, everybody, for your time today as we discuss and further our understanding of uterine tachysystole and uterine activity. So first, we would like to review our objectives for today's session, and those are to review the definitions related to uterine activity, to review the etiology and physiology of uterine tachysystole, and finally, to analyze the impact of uterine tachysystole on the fetal heart rate. So what are uterine contractions? Uterine contractions are quantified as the number of contractions present in a 10-minute window averaged over 30 minutes. To help prepare for today's session, we would like to discuss and review some basic terminology and physiology associated with uterine contractions. So let's begin with frequency. Frequency is how often contractions occur. Counted from the beginning of the contraction to the start of the next contraction and measured in minutes. Duration is how long contractions last. It's assessed from the beginning of the contraction to the end of contraction and measured in seconds. Intensity is how strong the contractions are, so the strength of the contraction. It's determined by palpation if we're monitoring externally, and typically noted as mild, moderate, or strong when using external monitors and palpation. The abdomen must be palpated and the patient queried regarding strength of contractions when using external monitors or auscultation and palpation methods. However, if we're using an IUPC, we measure that with millimeters of mercury. Here in North America, that's the most common unit of measurement when employing an internal. Resting tone is the measurement of the uterus at rest or in between contractions. It's assessed again via palpation or via millimeters of mercury if using internal monitors. When speaking about uterine palpation, it's good to know that the palpation of the uterus before, during, and after a contraction and enlisting input from the laboring woman provides us information critical to understanding a complete assessment of the quality and strength of contractions. So one way we can go about defining or assessing palpation is by using something all of us have at our fingertips, our faces. So whether we're training a new patient or training a new nurse, or helping our patient or their spouses and significant others to identify the difference between a mild, moderate, and strong contraction, we can utilize our faces as a guide. When assessing, for instance, a mild contraction, such as we see at the beginning of the labor process, we can use like the tip of our nose. So the tip of your nose is easily indentable, such as a mild contraction would be. A moderate contraction palpates more like your chin. So it's slightly indentable, but yet firmer than you would find at the tip of the nose. So slightly indentable, considered to be more in line with a moderate contraction. As opposed to your forehead. Your forehead, it cannot be indentable. It's firm with palpation, and that would be indicative of a strong contraction. So when palpating the abdomen during a contraction, if you palpate it firm, cannot be indented, very firm to the touch, so to speak, that would be considered a strong contraction, as we see during the active phase and towards the end of the labor process. Teaching the art of palpation is a very useful tool and helps us determine strengths of contractions, as well as asking our laboring women to help us with the pain scale as we go out throughout the labor to determine if our contractions are increasing in intensity. Moving on, let's talk a little bit more about contractions, and again, just trying to provide a framework for the rest of today's discussion. So contractions generate intrauterine pressure. They cause the retraction, effacement, and dilatation of the cervix. They help, therefore, to facilitate the descent and the birth of the fetus. They affect the maternal blood flow through the uterine myometrium, decreasing it and causing the transient intermittent interruption in oxygenation to the fetus. A normal contraction pattern is 5 contractions or less in 10 minutes. We'll be talking about the difference between a normal contraction pattern versus a tachysystolic contraction pattern. Let's dive a little deeper into resting tone. Resting tone is measured, again, by millimeters of mercury when using an IUPC, or by palpation if assessing externally. A normal resting tone helps to assist us in maintaining adequate fetal oxygenation by giving the fetus a period of relaxation between the contractions and allowing reoxygenation to occur. Hypertonus is an elevated resting tone. This would be a uterus that palpates firm and or more hardened and doesn't return to its pre-contraction soft state. If using an internal monitor such as IUPC, these would be pressures to in excess or greater than 20 to 25 millimeters of mercury. If we were, for instance, inducing a woman and we did not see the resting tones coming back to pre-contraction state or greater than 20 to 25 millimeters of mercury, we would need to adjust and give her that period of rest. So when we're counting and gauging for our internal monitors, we have 2 units of measurement. We measure in 10-minute segments, and one way would be to measure the peak intensity or amplitude of each contraction in millimeters of mercury and add that together. Another, for your MBUs, is to measure the peak intensity or amplitude in millimeters of mercury for each contraction in a 10-minute period, add those numbers together and subtract the difference between the amplitude and the resting tone at the peak of the contraction to get us the MBUs. So for example, if you had 3 contractions, each with an amplitude of 80, 80, and 75 respectively, with a 10 millimeter of mercury baseline, in essence, we would say 80 from 10 would be 70 for the first contraction, and 80 from 10 would be 70 for the second, and then 75 from 10 would be 65. If we take the sums of the 3 together, that would be 70 plus 65, giving us 205 MBUs. MBUs are the most common method of measurement here in North America, but we wanted to show that there are a few others out there in the marketplace. It tends to be we, as a as a whole, use the MBUs when we're counting out and documenting the units of measurement on the unit. So we wanted to show you that. And again, the example provided that we take the amplitude, subtract then the baseline, and add the numbers together within that 10-minute segment to give us an estimation of what we've seen within that 10-minute period. Let's talk a little bit about the physiology of contractions. During labor, the uterus is divided into two functional segments, the upper and the lower segment. The upper segment is considered the active portion of the uterus during the labor process, and it contains the pacemaker regions where contractions originate or generate from. Currently, there's been no specific pacemaker site that we can point to that contractions come from, but we do know they originate in these pacemaker regions, and that successive contractions tend to cause the smooth muscle fibers in that upper region to shorten and thicken with successive contractions. Likewise, they pull and retract on the lower, more passive uterine segment, causing it to thin and shorten, pulling on the cervix to help it to dilate and efface. We also know that at the beginning of the labor, various hormonal changes occur, such as an increase in the corticotropic releasing hormone, a decrease in progesterone, an increase in estrogen, prostaglandin, and oxytocin, and that together this process causes the uterine myometrium to go from a quiet to a more active state. Contractions, therefore, result when there is a coordinated propagation of myometrium contractions starting in the fundus of the uterus. That being stated, let's take a glance at the intramyometrial pressure's effect on the blood flow. We know that during the contraction, the maternal blood flow is reduced. This is directly related to the intrauterine myometrial pressure. Once that pressure exceeds 35 to 60 millimeters of mercury, those spiral arteries begin to be compressed. This entire process begins to have an effect on the fetal compensatory mechanisms. So that being stated, a healthy fetus has twice the reserve required to navigate the birth process. So a couple of things come into play here. Extrinsic factors that impact the fetal heart rate and intrinsic factors that can affect a fetal heart rate pattern. So extrinsic to the fetus means factors outside of the fetus, and intrinsic means factors internal to the fetus. So let's take a look at those. Some maternal extrinsic factors include maternal oxygenation status and the adequacy of maternal hemoglobin levels and cardiac output. So factors that would decrease maternal cardiac output or O2 content will have an impact on the fetal extrinsic factors and help determine blood flow to the uterus. So some things to consider here: maternal hyper or hypotension, asthma, CHF, cardiac defects, hypovolemia from conditions that result like abruption. So any of those things can have an impact on the extrinsic maternal influences. Now let's take a look at uteroplacental perfusion. Uteroplacental perfusion is impacted by the structure and function of the placenta and its surface vessels. So things like increased uterine contractions or hypertonus have a play here. So one of the conditions that would impact this would be drug-induced oxytocin hypertonus or tachysystole. An abruption causing the tachysystole could have a play. Maternal conditions such as hypertension, post-dates, placental infarcts such as we see with smoking, diabetes, or any vasoconstriction type factors can have an impact on your uteroplacental perfusion. Thirdly, let's look at umbilical circulation. So to discuss umbilical circulation, let's do a brief review of the umbilical circulation. So the umbilical cord would normally contain 3 vessels, 2 arteries, and 1 vein. The vein carries oxygenated blood from the placenta to the fetus. Arteries carry deoxygenated blood from the fetus to the placenta. Any abnormalities of the cord or cord compression can affect the circulatory process. So what are some factors that we would be speaking of? Things like the contractions, the tachysystole, true knots, nuchal cords. Anything that could affect the cord or its circulatory process can have a play with umbilical circulation and getting the oxygen back to the fetus. Next would be amniotic fluid. So that's the amount of fluid within the uterus. So we all know that amniotic fluid provides a cushion to the cord and to the fetus during the birth process. So be thinking of anything that might have a play there. Now let's take a look at some intrinsic factors impacting fetal heart rate patterns. Typically when we're talking intrinsic factors, we're speaking of the fetal circulatory system, and the fetal heart rate control, and the fetal adaptive compensatory mechanisms. So let's do a brief review here as well. So as we know, oxygenated blood from the placenta flows through shunts in the fetal systemic circulatory system. This allows for the preferential blood flow streaming patterns that we see that prevent mixing of oxygenated and deoxygenated blood. When we're speaking of fetal circulation, we know that fetal blood has an increased hemoglobin concentration that allows greater O2 carrying capacity. We know that fetal hemoglobin has a high affinity for O2 and that fetus has a greater cardiac output and a higher heart rate than the adult, which allows rapid circulation. This entire process facilitates O2 transport to fetal tissues. Decreased fetal heart rate has an impact on the myocardium, allowing it to decrease O2 consumption. This redistribution of fetal blood flow permits preferential shunting to vital organs when the fetus is compromised. This preferential shunting, as well as decreased O2 consumption, helps the fetus tolerate the stressors of labor and the birth process. With fetal heart rate control, we know that it's controlled by the parasympathetic and sympathetic nervous systems. The parasympathetic is largely in control at term of pregnancy, also the primary controller of variability. Recognizing moderate variability indicates a well-oxygenated fetus without acidosis. Adaptation supports effective exchange of respiratory gases and aerobic metabolism. Fetus has a compensatory reserve. We know that the placental transfer capacity at 100% indicates the fetus has 2 times the reserve needed to navigate the birth process. Once that capacity falls to 75%, we start to see SGA, or small for gestational age, or IUGR. At 50% is when we would start to see fetal compromise. So let's look then at uterine tachysystole. Uterine tachysystole is defined at greater than 5 contractions in 10 minutes, averaged over 30 minutes. A mathematical equivalent to that would be greater than 15 contractions in 30 minutes. So what are some causes of this tachysystole? We know one of the most well-known would be an iatrogenic effect of induction and augmentation. So if you see a pattern and you feel that that is in fact tachysystole and the woman is being induced, one of the prime interventions would be to stop the induction agent. If we cannot stop it, then it might be, this patient might be a candidate for our beta sympathomimetic drugs in order to space those contractions out. It can also be a result of spontaneous causes, such as intrauterine infection, in that there's an irritation of the myometrium by the bacterial toxins. Tachysystole has also been noted with the use of cocaine. Tachysystole can also come from an unknown etiology. We don't know the exact cause. The primary goal here is to recognize the pattern and be able to implement our intrauterine resuscitation measures to stop the pattern, so to be able to intervene and space the contractions out, allowing our fetus to recover and employ its compensatory mechanisms, or intervene prior to those being necessary. that being stated, I would like to now hand it over to Dr. Emily Hamilton so she can give us a deeper dive into the physiology behind uterine tachysystole. We hope the brief overview of basic functionality and definitions was helpful as we proceed to go deeper into the physiology. Dr. Hamilton?
Thank you, Michelle. This is a graph taken from women in labor, and you'll see the fetal heart rate on top, contractions on the bottom, and the red line is demonstrating the baby's transcutaneous oxygen saturation. The vertical arrows that are falling are there to show how oxygen levels at the baby level, the fetal level, change in timing respect to the contractions. And you can see that the lowest level is a little bit after the contraction. That is, during the contraction, as Michelle mentioned, uterine blood flow is reduced through the myometrium, less oxygen delivery to the baby, and once the contraction has passed, that intervillous space blood is transmitted to the baby, and we see a slight dip in the fetal oxygen saturation. But normal babies will tolerate that very well. Here is another experiment. This is an experiment in fetal sheep. It's actually an experiment in which the fetal sheep have complete cord compression. Now, that's not the same as a contraction, of course, but it does demonstrate a very severe form of impaired oxygen delivery to the baby. And this experiment is very illustrative of what happens when that happens very frequently. So, in the first experiment, the compressions were 1 minute in duration, and they occurred every 5 minutes, very severe, complete. You can see the fetal sheep develop severe decelerations, but all of these sheep, despite 4 hours of this happening, maintained normal pH and were healthy at birth. In the second panel, exactly the same experiment, except the occlusions now happened 2.5 minutes apart. As you can see again, very severe decelerations as outlined in red. Every single one of these fetal sheep developed a severe acidosis. In fact, every single one of these sheep developed brain lesions. So if the compressions are severe and frequent, the fetal sheep does not have time, even with good compensatory mechanisms, to completely compensate for the reduction in oxygen delivery. So when we are considering the effect of contractions, it is important to consider that oxygen available to the baby correlates with contraction strength, higher contraction pressures, less blood flow. With the duration of the contraction, longer contractions, and that impediment lasts longer, and the interval, because that's when the baby can recover. So reperfusion time is very important to restore oxygen levels in the intervillous space before the next contraction begins. So what is the incidence of uterine tachysystole? Well, you can see here 6 different studies and 6 different instances. And I'd like to begin with the paper by Becker, because it's one which is very frequently quoted in any discussion of uterine tachysystole. And in this study, there were 2 groups of patients, a control group where the pH was normal, and an adverse outcome group where the babies had acidosis, pH is less than 7.11. And using computer analysis, they counted and calculated the frequency of contractions, and you can see that the average frequency was 4.8 in the control group and 5.0 per 10 minutes in the acidotic group, and that was different. Babies with acidosis tended to have more contractions than those who were normal in the first stage. And there was also a difference in the second stage, 5.2 per 10 minutes in the control and 5.5 in those with acidosis. Again, acidosis associated with more contractions than babies who were normal. Now, in this particular study, the actual incidence wasn't reported, but it must have been very high, the incidence of uterine tachysystole, because if on average your number of contractions per 10 minutes is more than 5 per 10 minutes, that means half of your patients are having even more and half of your patients are having less. So one would estimate that the incidence of uterine tachysystole in this study was somewhere around 50%. Now let's look at some of the other studies, and you can see quite a variety here. Dr. Rice-Simpson looked at the incidence in patients undergoing induction of labor and found it to be around a quarter of the patients. These other studies are involving patients not necessarily induced, but a mixture of induced and spontaneous. And you can see rates that range anywhere from 13 up to 98%. Paper by Clintz is very much an outlier. I don't think any of us experience that almost all patients with inductions at term will develop uterine tachysystole. And nevertheless, it is one of the publications, one of the smallest studies on this topic. So uterine tachysystole is in fact fairly frequent. Now, in the paper by Smith and al., they also looked at how long did the uterine tachysystole last. And on the horizontal axis here, you can see different durations of uterine tachysystole. So about 5% of mothers had uterine tachysystole, which just lasted 30 minutes. That is, it merely appeared and within the next 10 minutes was gone. A smaller percent where it lasted 40 minutes, 50 minutes, 60 minutes. So about only 4% of patients will have uterine tachysystole that will go on beyond an hour. Far different from those animal experiments that I showed you earlier. So while it's relatively frequent, it's generally fairly transient. All right, let's look at the outcome of the babies depending upon the presence or duration of uterine tachysystole. So in the group that had no uterine tachysystole, a large study, 5,000, 1.3% developed neonatal depression. And what do we mean by that? Babies where the base deficit was over 10 or the 5-minute APRA was 6 or less. In the group who had any uterine tachysystole, about 1% developed neonatal depression. When the tachysystole was less than an hour, 0.7, and over an hour, 1.9. So you can see a tendency that the rate of depression is greater when it lasts longer, but even over 60 minutes, it's relatively uncommon. In this study, we looked also at rates of uterine tachysystole depending upon the utilization of oxytocin, and the highest rate, in fact, a number very similar to what Dr. Rice-Simpson found, about a quarter, just under a quarter of the patients with augmentation had uterine tachysystole. Now let's look at how many had neonatal depression in those three groups, and you can see that it's less than 2% and relatively similar. But the most important question is, if they had uterine tachysystole, what percentage went on to develop neonatal depression? And you can see that it's around 1 to 1.7%. So what is different about those patients? Why did they get into trouble? Well, some patients tolerate uterine tachysystole much less well than others. And in this graph, we're looking at the average number of decelerations in the vertical column compared to how many contractions they were having. So as contractions per 10 minutes became more frequent, as we move to the right, you can see that the number of decelerations also increases. But what's very dramatic here is that the babies with neonatal depression at almost every level of contractions were having more decelerations. That is, their compensatory capacity was less. They tolerated uterine tachysystole very poorly. You can see when they're up around 6 and 7 contractions, they have a lot of decelerations compared to the green, the normal. But they also had more decelerations at almost every level of contractions. This is just another way of looking at rates of uterine tachysystole. Here, we're looking at the rate not as in the group in general as a whole, but at particular points in labor. So as we move towards the right, we're getting closer and closer to birth. And you can see in the greens, the normals, babies with normal gases at birth, rates of uterine tachysystole are quite low, and they gradually increase as we get close to delivery. And in the babies with base deficits over 12, they also increase, but much more. It's just before birth. And again, if we look at their response, this graph shows the response in the number of decelerations per contractions over time. The babies in green tolerate their contractions quite well. They do tend to have more decelerations per contractions because the contractions are stronger and often more frequent as we get close to birth. But the babies with metabolic acidemia have many more contractions, and they do that for a long period of time. The red here are babies who not only have acidosis but also developed encephalopathy, seizures, etc. after birth, and you can see that they have an even more exaggerated response to contractions. So decelerations are a very key consideration when you're looking at the baby's response to contractions. So in summary, uterine tachysystole is relatively common. The usual range is around 11 to 26%. It's usually short-lived. How a baby responds to UT depends upon its balance between contraction-related decreases in perfusion and the compensatory capacity of the baby. Most babies have good compensatory capacity. However, it's not unlimited. Compensatory capacity is finite. Red flags to look for are what is the deceleration response to any level of contractions, and also to consider what's causing the UTs. Why? Well, if it's related to oxytocin, that's relatively easy to correct. Stop the oxytocin, short half-life, it's gone pretty much in a few minutes, and the baby should recover. Whereas if the underlying cause is one of those things such as chorioamnitis or abruptio placenta, that's different. Abruption, we can't modify its course, and it may deteriorate very quickly. So always consider what's causing it as well as what can we do about it. Now, we have some interesting case presentations, and so I'm going to pass this back to Michelle, and we're going to go over 4 different cases.
Thank you, Dr. Hamilton. So as we begin our review of some cases here, we would like to acclimate you to the strip you're seeing. Across the top here, you would see a 30 minutes of tracing that include the fetal heart rate and contraction. Directly below this tracing, you'll see a 4-hour condensed view. At the very bottom is a persistent contractility index with markings at 0, 15, and 30 respectively. The orange markings signify tachysystole being detected. There is a small magnifying window, small slider window to the far right of this tracing, and that portion within that window is the 30-minute tracing you're seeing displayed across the top. That being stated, let's take a look at this first case. This is a G3, P1, 39 and 5/7 week, just female. Our compressed view here shows a 4-hour trend beginning at approximately 11:30 and starting to show a period of tachysystole that starts right at 12:45. We begin our review state here at the top at about 15:54, and we show that we have some variability present. And as we continue to look at the right, we see that there's some decels here with our contractions. You can see that we start pushing about mid of that upper strip, with a delivery resulting at about 15:22. As we review this strip, we can tell this infant was able to maintain a normodotic state, delivering with a pH at 7.35 and a base deficit of 0.6, with a resulting APGAR of 8 and 9. As we review the strip, you can tell this baby was able to accommodate a 2.5-hour period of tachysystole. Again, across the bottom, you see this orange period. where that tachysystole started right at that 12:45 mark, but due to the compensatory mechanisms and the fetal reserve of this infant, it was able to tolerate. We see it was decelerating with the contractions, but it maintained its variability and again was able to deliver normodotic and APGARs of 8 and 9. Now let's take a look at our next one. This is 4 hours before delivery. As you can tell, your little slider window, the magnification window, is here at the beginning of that 4-hour compressed view, and this view began at about 1900. So if we look across the top here, it starts at 1908 and ends at 1928. We can see there's some variability present, and that we're decelerating towards about mid-strip to the end. We're decelerating with the contractions. We've got about an hour of tachysystole depicted across the bottom compressed view, beginning at about 2000, going through about 2100. Looks like it corrected for just a little bit of 30-minute time frame or so, and then started again at about 2145 into a tachysystolic state. So if we continue to look and we move our slider window to the end of the strip right here at delivery and look across the top, see what we find now. So again, at about 2145, where that sustained tachysystolic state continued, at approximately at the top 2228 and going through 2256, we see decels with every contraction. The baseline decreases at about 2139, and the decels begin to get a little deeper and wider with a more smooth pattern. So a smoother baseline. Looks like it's beginning to lose some of its variability. More importantly, they're getting wider and deeper with each contraction, falling at the end of the contractions even. So it's been in a period of tachysystole for roughly 2.5 hours with that one little break where it tried to recover, but then a sustained 1.5 hours of tachysystole with a resulting vaginal delivery pH of 7.04 and a base deficit of 13.3. However, it was able to have APGARs of 8 and 9, demonstrating it was able to compensate. But this compensatory capacity is finite. We would consider this a near miss. This patient, rather, was sustained in a tachysystolic state for about 2.5 hours, or at least sustained for 1.5 hours, delivering with that 7.04. Even though it was an 8-9 APGAR, one would have hoped we could have intervened and spaced those contractions out a bit, allowing this baby to have a rest in between to recover from the contractions coming so rapidly back to back. Now let's go on and look at our next one. This is case number 3. Again, our slider bar magnification windows here at the end right at delivery. And this is a G3, P1, 39 and 3/7. We can see that our compressed view began, and we are looking at our tachysystole beginning at about 1500 and lasting through about 1630, where it it corrected for a brief time and then started again at 1730 with a resulting delivery at 1854. If we look across the top here at this last 30 minutes of strip, we see our baseline has started to be in a tachycardic state at 180 with decels at every contraction. The rapid deterioration there right at delivery. Tachysystole was sustained for about 1.5 hours. It's a resulting pH of 7.05 and a base deficit of 16.2. But yet again, the baby was able to compensate and deliver with APGARs of 8-9. This is yet another example of what we would consider to be a near miss. The goal would have been to implement some interventions that could have spaced these contractions out and perhaps allowed this baby to recover a bit prior to delivery, or to expedite that delivery if that hadn't have been the case. Our final case presentation is another example of tachysystole and a resulting pattern. So with this one, the strip started at 1900. This is a G1 P0, 39 and 07 weeks. Our tachysystole began at about 2115 and tried to autocorrect a bit and then got persistent at 2145. the end of this particular strip segment is 2247. So this is right at about 1.5 hours of sustained tachysystole with a resulting pattern as you see depicted. These are considered deep and wide decels with a smooth baseline. This would be an ominous pattern. This would be one of those that just has no determinable baseline. These are deep, wide, with every contraction. You have no variability that can be spoke of, and truly this would be one of the most ominous we would come across. So in reviewing, this pH, resulting pH is 6.6 with a base deficit of 27 and resulting APGARs of 0 and 0. To sum up, recognizing the tachysystolic patterns and beginning our interventions exponentially, then calling for assist as needed, and then knowing when to escalate as appropriate per our unit protocols is of most importance. With that being stated, I would like to hand it back to Dr. Emily Hamilton so we can now discuss deeper the medical legal perspective of uterine tachysystole.
Thank you. Yes, we have a few slides here to show some experiences with the medical legal aspects. First, a number of studies, all a little bit different, mostly looking at oxytocin use and uterine tachysystole and adverse outcome. These studies all come from different places in the world, and they're all showing more or less the same thing, that with severe brain-related injury, like that last case that Michelle just described, rates of oxytocin misuse, uterine tachysystole, and delayed reaction to the tracing are very prevalent. Now, one of these studies by Dr. Johnson, in fact, provides quite a bit of information comparing different subtleties about this subject in both the metabolic acidosis group and in normal. So we'll look at that one in a little bit more detail. The definition of UT here is a little bit different from what we use in North America. It's greater than or equal to 6 contractions per 10 minutes lasting at least 20 minutes. It's similar, but not identical. And what did they find? Well, they found oxytocin misuse in about 47%, almost half, of the babies with severe metabolic acidosis. But oxytocin misuse doesn't necessarily mean uterine tachysystole. It may mean simply increasing or failing to decrease oxytocin at the rate specified in a protocol. But when they separated out how many actually had UT, it was about 19%. And, as we've mentioned before, uterine tachysystole may occur in the absence of oxytocin for other reasons, and in fact you can see there was an additional 7% who had uterine tachysystole but without oxytocin. So overall, about a quarter of the babies with metabolic acidosis, severe, seeking legal action, had uterine tachysystole. That's a very substantial portion. They too looked at a group that were normal and looked for these same things, and you could see the same color coding here, oxytocin with uterine tachysystole at 3.2%, uterine tachysystole without oxytocin misuse, 3.7%. So in total, about 7% of normal patients would have uterine tachysystole, and they did just fine. So you can understand why people become blasé about uterine tachysystole. But we have to remember, not every baby can tolerate that. There's really no excuse for causing it. And if we get to those babies with very bad birth-related injuries, that problem is very prevalent. So I'm going to pass it back now to you, Michelle, for a few final conclusions.
Thank you so much, Dr. Emily. So in conclusion, we know that fetal tolerance is demonstrated by changes in the fetal heart rate. Our ability to recognize a decreasing variability or changes in baseline and decels is extremely important in our labor management. Understanding the potential underlying cause and the appropriate interventions to take to correct is critical. Knowing to turn the patient to her side, begin the O2, initiate the IV bolus, call for assist, discontinue the Pitocin if in use, or expedite labor if one of the other underlying causes for tachysystole have been identified, all play critical parts. Utilizing all the tools at our disposal to ensure we are aware of changes in the fetal heart rate and contraction pattern in order to intervene rapidly prior to the fetus exceeding its reserve capacity can all have a tremendous impact on outcome. We also realize that uterine tachysystole and/or the failure to intervene for abnormal fetal heart rates is very common in OB litigation. So again, recognizing these patterns, assessing the cause and initiating appropriate interventions, calling for assist, and then escalating as appropriately all play critical roles. You can even use a RACE acronym to help you remember. Oxytocin management protocols and checklists are all critical at the bedside to help us understand and prevent tachysystole and its impact to the fetus. Documenting appropriately all the measures we have taken to correct the pattern is very important. And finally, avoiding the tachysystole, stopping iatrogenic causes such as the oxytocin, expediting labor for those if it is a suspected abruption, so employing the proper interventions for the probable underlying cause, because ultimately failure to do so is indefensible. So we would like to thank you guys very much for your participation today. We hope it's been helpful in reminding us of some of our physiology, the appropriate interventions to take, and we look forward to seeing you in future presentations.
So our first question is, can you please comment on the management of uterine tachysystole when the contractions are frequent but very mild?
Yes, I can take that one, Lynn. And I think it's a great question, and it demonstrates several of the points that we tried to make. So the first one is immediately look to see whether or not they're decelerations, because if they're decelerations, we don't really care too much what the frequency or the strength of those contractions is. We know we have to do something to assist that baby. Second is, why is it happening? Is it oxytocin related? Is it potentially abruption related because it changes our idea of what may come in the future? And third, is she on oxytocin? And of course, if she is, you need to reduce it. Now, we all know that if the contractions are not intense, there's not such amount of intramyometrial pressure on those arteries, and flow won't be as impeded compared to those that are very strong. Same thing for short contractions versus long contractions. The duration of impeding the flow is less if they're short. And the interval, as we mentioned before, is important for recovery. However, if your protocol in your institution says stop oxytocin with uterine tachysystole and there's no special caveat given for these things, then that's what you should do. But please do remember to think about what is the cause, and of course, look for all of those other informative fetal heart rate signs.
Our next question is also for you. Did you compare, and I believe this has to do with the publication titled Clinical Associations with Uterine Tachysystole, headed by Sam Smith. Excuse me. Did you compare the frequency of uterine tachysystole for greater than 1 hour during the first stage of labor? Was it more common in latent, active, or transition, induced, or spontaneous labors?
Well, we certainly looked over the course of labor. We weren't able to define it by transition, but we could look certainly first stage and second stage, and it's least common in early labor. and it's most common as you get towards the end, so in the second stage. Induced or spontaneous, it's the same general pattern. The longer labor goes on, the more frequent and the stronger the contractions are, and the longer the period of uterine tachysystole. I must say, we did 2 studies with that institution, and the difference between the 2 studies was quite remarkable. It was over a number of years. And in the second study, we'd seen a tremendous reduction in uterine tachysystole because we had introduced, well, they had introduced a number of things, including empowering nurses to turn off the oxytocin if they felt uterine tachysystole or fetal heart rate conditions merited. They didn't have to call for agreement. But we also provided with them those graphs where you could see color-coded anytime uterine tachysystole happened. And just over the course of 4 years, we saw a tremendous drop in the rate of uterine tachysystole. So what you might see in one institution doesn't necessarily apply to another, but the same general tendency that UT is most common towards the end of labor, I've seen in multiple places in multiple analyses.
Our next question, and I'm going to leave it to you and Michelle to decide who answers Dr. Hamilton, is when using oxytocin in the presence of uterine tachysystole, we first decrease the oxytocin in half if no resolution happens in 20 minutes. We then stop the oxytocin. I'm sorry. When the uterine activity goes back to normal, is it appropriate to begin oxytocin again? Thank you.
From my perspective, I would say you would go to your protocol, and that is the protocol. If the uterine activity went back to normal, it's appropriate to reinitiate. Dr. Emily, what would your perspective on that be?
I think that's very reasonable. You know, oxytocin is a very useful drug. It's no secret that it's useful. That's why we use it in approximately 50% of patients in labor. So to deny people the value of oxytocin for no good reason is a problem as well. So yes, we must be judicious in its use, but we must also be reasonable in allowing clinicians to use it and their patients to derive the benefit from it.
The only thing I think I would also add to that would be, if once it reinitiated, we would just be diligent about watching the contraction pattern as well as the fetal response to it. But again, you have protocols in place for that, and I would follow those unit protocols. But absolutely, we use it for a reason, to initiate the birth process. So following those protocols and then being diligent about recognizing the strip and the fetal response to the contraction.
The next question, is there a consensus on the maximum number of Montevideo units that are acceptable?
We tend to look for 200 to 225 to establish an adequate labor pattern. Dr. Emily, what are your thoughts on that?
I think that's reasonable, but truly there isn't a great deal. You've asked a very complex question, and I certainly agree with your answer, Michelle. 200 to 225 is what we look for when we're trying to determine whether labor is progressing adequately and wondering how to apply those rules given a certain level of uterine activity. But remember, every baby has different responses, so you must always consider what the baby's response is. But has there been a study looking at the absolute optimum level of Montevideo units? I'm not aware of one.
How do you address management of tetanic contractions?
Well, the first thing that you do is you stop the oxytocin and you try to provide resuscitation for the baby. And if you have to provide uterine muscle relaxants, yes, that's possible as well. But the first thing is get the oxytocin off, improve perfusion to the baby, and oxygenation to the mother. Michelle, would you ready to add?
No, I completely concur. The first thing is to recognize that and perform your intrauterine resuscitation measures and turn that pit off if it's running. And to your point, if it was spontaneous or oxytocin-induced, to use your muscle relaxants if necessary.
Okay, we have 2 more questions. so far. Do you see more UT with the use of Cytotec? Sorry.
I'm not sure more than what, but Cytotec certainly is a cause of uterine tachysystole.
And what do you know what the long-term, and this word is literal, sequel is for infants who are acidotic at birth but have good APGARs?
It's generally very good. If they have good APGARs and they don't develop neonatal encephalopathy, their outcome will be very good. I'd like to know what the degree of acidosis is, obviously, but as a general rule of thumb, if your base deficit is around 12, which is quite significant, about 1% of babies will be there, 75% of those babies will do just fine. So acidosis doesn't mean injury. It means you're getting close to the edge of the cliff, where you might fall off and get into a lot of trouble very quickly, but it is not equivalent to injury or neurological sequelae.
And that's the end of our questions. Again, I thank you for joining us. It has been an honor to host this